Hello everyone, Professor Vig here. Welcome to your lecture on the upper GI disorders. The previous lecture we covered the overview of the GI system and diagnostics and treatments. And in this one, we're going to cover the upper GI disorders. Then following this, we have the lecture on the liver and pancreas, and then lower GI tract. These are the learning objectives for this lesson. So let's start with the hiatal hernia. Hiatal hernia occurs when a portion of the stomach basically protrudes through the hiatus, the opening in the diaphragm, and this enters the thoracic cavity. Now, while the digestive tract is normally loosely attached to the diaphragm, like certain conditions can cause the stomach to shift upward, and this leads to significant discomfort and functional issues. Now, there are two distinct types of hiatal hernias that we see clinically. The most common is the sliding one. So we call it the sliding hernia. In this version, the gastroesophageal junction and a portion of the stomach move above the diaphragm. This is highly positional, meaning it often occurs when a patient is lying down and may slide back, into the abdominal cavity when they stand up. So it's positional, it can move. The second type is the rolling or the paraesophageal hernia. Here, the gastroesophageal junction stays in its normal place, but the fundus of the stomach moves up through the enlarged or weak hiatus. This type is particularly concerning because the blood vessels in the stomach wall can get compressed, which can lead to ulceration. Now, what causes these hernias to develop? The etiology often involves a combination of structural and environmental factors. It can be caused by congenital shortening of the esophagus or a natural weakness in the diaphragm. Also, anything that can significantly increase the intra-abdominal pressure, such as pregnancy, obesity, chronic coughing. These can force the stomach upward through the hiatus. Now, because hiatal hernias often makes the lower esophageal sphincter incompetent, the most common symptom is heartburn, known as pyrosis. Patients frequently report a sour taste in the mouth or frequent belching. A key diagnostic clue is that the substernal burning sensation typically increases after eating or bending over or lying down, as these actions facilitate that reflux of gastric contents. Now, to confirm the diagnosis and assess the severity of it, there are several tests that can be used. As we mentioned, the GI system overview lecture. Please, you can review, look at that for more details on these tests. But basically, the upper endoscopy allows for direct visualization of the esophagus and stomach protrusion. X-rays of the upper GI tract can show structural displacement. Then the ambulatory acid probe test monitors the frequency of acid reflux, and the esophageal manometry is used to measure the rhythmic muscle contractions and pressure within the esophagus. Treatment primarily focuses on reducing the reflux and preventing the stomach from sliding upward. So basically, patients are advised to eat small, frequent meals rather than large ones to reduce stomach distension that increases pressure. Most importantly, they should avoid a recumbent or lying down position immediately after eating because the gravity when you're sitting up helps the stomach and its acidic contents, stay in their proper place. Then we have the gastroesophageal reflux disease, GERD, as known. And this is very common in clinical settings. This is characterized by a periodic backflow of acidic gastric contents into the esophagus. GERD often occurs in conjunction with structural abnormalities, such as a hiatal hernia. This can compromise the natural barrier between the stomach and the esophagus. So the development and severity of GERD are primarily determined by competence of the lower esophageal sphincter, the LES, and and the pressure differences on either side of it. Now the reflex occurs when the LES pressure decreases or the intra-abdominal pressure increases. This allows the gastric contents to move upward into the esophagus. And delayed gastric emptying can also contribute to this by prolonging the presence of food and acid in the stomach. because we even have some medications like Ozempic, for example, is very popular for weight loss. It delays gastric emptying. And so basically, this can cause a lot of problems because now the food is just the acid can get pushed upward and cause, heartburn. Now, because the esophagus is not designed to withstand this gastric acid, because remember the gastric acid, the pH is very low. That means it's very acidic, and the esophagus is not used to those kind of acid levels that belong in the stomach, right? So these frequent refluxes can cause inflammation and ulceration of the esophageal mucosa. And over time, chronic irritation can lead to fibrosis or scar tissue formation. It results in esophageal strictures that narrow the lumen and make swallowing difficult. Hallmark signs of GERD is heartburn or pyrosis, a burning sensation behind the sternum that typically occurs 30 to 60 minutes after eating or when lying down. Symptoms could be aggravated by substances that reduce the LES pressure. These include caffeine, fatty foods, alcohol, cigarette smoking. There are a lot of different diagnostic tests that we can use to evaluate GERD. We have the upper endoscopy that allows for direct visualization of the esophageal mucosa to assess for any inflammation or ulceration. Then we have the ambulatory acid probe test, which measures the frequency and duration of acid reflux episodes. Then we have the esophageal manometry, which evaluates the esophageal contractions and LES pressure. And GI X-rays help identify structural abnormalities, such as the presence of a hernia. Now, treatment focuses on reducing acid exposure and promoting healing. Antacids neutralize the existing acid in the stomach. H2 receptor blockers decrease acid production, and proton pump inhibitors, PPIs, they work by suppressing acid secretion. So they work in different, ways. All of this decreased acidity will help promote the mucosal healing. And in some cases, medications could also be prescribed to strengthen the LES. Now, long-term management basically includes important lifestyle modifications, avoiding dietary triggers such as spicy foods, alcohol, caffeine, and fatty foods, stopping, smoking, eating smaller and more frequent meals, avoiding lying down immediately after eating. All of this helps to minimize the reflux and reduce the symptoms. Then we have peptic ulcer disease, which is also commonly seen in clinical settings. This often occurs when single small round cavities with smooth margins penetrate the submucosa of the digestive tract. Remember the different layers of the digestive tract we covered in the overview lecture? So this basically penetrates into the submucosal, lining. This most frequently this happens in the proximal duodenum or the antrum of the stomach. This damage is driven basically by an imbalance between the mucosal defense and damaging forces like powerful gastric secretions, which lead to breakdown of the protective mucosal barrier. So basically, the first lining, remember, was a protective mucosal barrier that gets, broken into, and then it goes into the submucosa, which is the supply center, remember, of the GI tract. Now, once this barrier is breached, the acid and pepsin enter the wall and erode tissues deep into this layer. This can damage, blood vessels or cause hemorrhage or even perforate the wall entirely. Now, while infection with H. pylori is the primary underlying cause in most cases, other factors such as the use of alterogenic drugs like aspirin or NSAIDs, chronic smoking, severe stress can also, weaken the mucosal lining. Clinically, patients will typically present with a burning or aching epigastric pain that follows a distinct cyclic pattern, so often occurring 2 to 3 hours after meals or during the night. And the discomfort is relieved by eating food or, taking antacids. So remember with, hiatal hernias, the discomfort started after eating food. Eating food actually helps relieve the discomfort for PUD. Now, to confirm PUD and rule out malignancy, clinicians usually use fiber optic endoscopy for direct visualization. and, and then perform biopsy to check for H. pylori. The treatment is comprehensive, focusing on eradicating the infection through a combination of antimicrobials, basically, to get rid of infection, reduce production and with proton pump and production of acid with using maybe PPIs or H2 receptor antagonists, and applying coating agents like superphate to provide protective covering to allow for healing. Then we have finally gastric cancer, primarily adenocarcinoma. It's a malignant tumor arising from the stomach's mucus glands. Because its early symptoms are notoriously vague, it's frequently not diagnosed until an advanced stage because, it could look like a lot of other different diseases. Now, this contributes to a generally poor prognosis because by the time it's diagnosed, it's already at a later stage. Now, pathophysiologically, most tumors occur in the antrum or the pyloric area, often appear as ulcerative lesions within irregular like craters and raised margins. And though they can also infiltrate the gastric wall or appear as polyp-like masses. The disease progresses from mucosa to the muscularis and then eventually spreads to the serosal layer, then regional lymph nodes and liver and even the ovaries, and it just keeps spreading. Key contributing factors include chronic H. pylori infection, a diet high in smoked foods and nitrates, genetic influences. Notably, the disease is more common in individuals with blood group A. Clinically, early signs and symptoms like anorexia, mild indigestion, and persistent feeling of fullness, they're often ignored or self-treated. People just get over-the-counter stuff to treat those. Now, advanced stages, these present with severe weight loss, iron deficiency anemia, occult blood in the stool. And that's the reason why monitoring for those is so important. The diagnosis relies on fiber optic endoscopy with biopsy and barium x-rays to visualize the stomach lining. Treatment typically involves gastrectomy, surgical resection, paired with chemotherapy or radiation. Now, notably, post-surgical patients require lifelong vitamin B12 injections because the removal of the stomach eliminates the production of intrinsic factor, which is essential for B12 absorption in the ileum. So that is it for our disorders of the upper GI tract. The next lecture, we're going to cover disorders of the livers and the pancreas, and then we will move on to the lower GI.